Hello, Jai Gurudev. I am Shakti Suprayukti, working as a MSc tutor of Faculty of Nursing in Sri Sri University. Today I discuss ancient topic GI abstraction. Firstly, to know about the learning objectives of GI abstraction. In learning objectives, what we learn? First, number one is definition of GI abstraction. Then types. It is mainly two types: mechanical and functional GI abstraction. Then to know about the causes or risk factor of GI abstraction, pathophysiology of GI abstraction, and clinical manifestation, diagnostic evaluation of GI abstraction. Then management like medical management, surgical management, and nursing management of GI abstraction. And lastly, to know about the preventive measure of GI abstraction. Firstly, we discuss about the introduction of GI abstraction. In introduction, we know GI abstraction is a blockage in the digestive tract that prevent the normal movement of the food, fluid, and gas. It may occur the stomach, small intestine, and large intestine, and it can be partial or complete. Then to know about the definition of GI obstruction. Definition is GI obstruction is a medical condition in which there is a mechanical or functional blockage in the digestive tract that impair the movement of the intestinal content, leading to the symptoms such as abdominal pain, distension, vomiting, and inability to pass the stool or gas. Then to know about the types of GI obstruction. Types, it is mainly two types. Number one is mechanical obstruction and number two is functional obstruction. In mechanical obstruction, to know about a physical barrier block the passage in the intestinal contact. For example, tumor, adhesions, hernias, inspection, and volvulus. Firstly, to know about the tumor. Tumor is a narrow or close the intestinal lumen. And secondly, to know about the adhesion. Adhesion forms after surgery that full the intestine. Then hernias where there is a portion of the intestine become trapping. And intuspection is occurring when the part of the intestine side into the another. And lastly, to know about the volvulus is the twisting of the intestine. Then second obstruction is functional obstruction or adynamic obstruction. In there, the GI tract fails to function without a physical blockage, usually due to muscle or nerve dysfunction. For example, paralytic ileum, postoperative ileum, and neurological disorder. Firstly, paralytic ileum. Paralytic ileum is where the intestinal motility is reduced or absent. Then secondly, postoperative ileum. Postoperative ileum is occurs after the abdominal surgery. Then neurological disorder, for example, spinal cord injury, and it is in this one is the disrupt the nerve signal need for the bowel movement. Then to know about the risk factor, like what are the risk factor that cause the GI obstruction? First, number one is the any previous abdominal surgery or any abdominal or inguinal hernias. Then tumors in the abdomen, advanced age, chronic constipation, inflammatory bowel disease, then immobility or prolonged bed rest, continues to rest in the bed. Then neurological disorder or any history of the abdominal trauma, then gallstones and electrolyte imbalance. In there are abdominal inguinal hernia that trap the some segment of the bowel that cause the obstruction. And also any abdominal surgery, like previous any abdominal surgery that forms the adhesions and also strict the intestine tract. And tumors with the abdomen that can compress or block the intestinal lumen. And the advanced incidents and also chronic constipation that may cause the facial impactation and also blockage. Then inflammatory bowel disease such as Crohn's disease. Crohn's disease is the ongoing inflammation and that cause the scarring of the abdomen. And immobility or prolonged bed rest that show the intestinal movement and increase the risk of the functional problem. Then neurological disorder, that one also cause the control the bowel activity and also nerve signal that one also control the bowel activity, such as result scarring and structural changes. Then gallstone it was the rarely entering the intestine and also cause the obstruction. Then to know about the causes. What are the causes? Causes is one is adhesions, hernial tumor, strictures, volvulus intuspection, then foreign bodies, gallstone, and pressure. First, adhesion from the after the surgery of hernia can be trap the intestinal loop with the hernial sac that also lead to the blockage. Then stricture and tumor either growing the inside the intestine and also presses from the outside. It can narrow intestinal passage. Then to know about the pathophysiology. In pathophysiology, according to causes that can lead to the pathophysiology. First, number one is any obstructional development. Obstructional development that also blockages the functional blockage and also it can prevent the normal movement to pass the food, fluid and gases. It can also cause obstruction and blockage the GI obstruction that leads to the proximal accumulation. Proximal accumulation is above the site of the obstruction that lead to the distension or cause the obstruction. Then that leads to the increase the intraluminal pressure. When proximal accumulation occurs, then gases and or fluids that accumulate the abdomen that cause the increase the intraluminal pressure. Then that leads to the reduced blood flow because of storage and blockage the obstruction occurs that cause the increase intraluminal pressure also that leads to the reduce the blood flow. Then after that that leads to the fluid secretion at loss. So that due to blockage and reduced blood flow, so that cause the fluid secretion and also load loss. Then that leads to the prolonged obstruction or continuous obstruction. Then that one is also cause the complication, and complication is like cause the due to reducing blood flow that cause the ischemia. Okay, all are understood. Then after that to know about the clinical manifestation. In clinical manifestation, what are the sign and symptom we see? First number one is the abdominal pain, then abdominal distension due to blockage occurs, then nausea and vomiting because of the obstruction occurs that cause the nausea or vomiting, then inability to pass the stool or influence because of obstruction and also cause the constipation and dehydration, then hypoactive or absence of the bowel sound, then sign of the shock and cause the fever because of infection and inflammation is present. Then after that to check the diagnostic evaluation, mainly history collection, firstly history collection and physical examination. In history collection, physical examination to check the abdominal pain, distension, any vomiting occurs or not, then constipation, then check for the hernias, any surgical scar is present or not, or masses. Then imaging study, in imaging study to check the and also to diagnose the abdominal x-ray, then CT scan of the abdomen, then to check the ultrasound, then laboratory test to check the CBC or complete blood count, then electrolyte, then renal function test. Then after that to know about the prevention. Okay, in prevention what we prevent? To maintain the high fiber diet, mainly GI obstruction we give the high fiber diet, then ensure the adequate hydration, then provide fluid to check the and also maintain the fluid electrolyte balance, and early mobilization after the surgery to prevent the paralytic ileum. Already you know the functional cause. In functional cause paralytic ileum present, so we promote the early mobilization after the surgery. Then maintain the chronic condition properly, then monitor and manage the constipation in elderly or mobile patient, then avoid the gestation of the foreign bodies, then proper care and maintaining the introing catheter or feeding tube, and also provide the nasogastric tube feeding, then timely treatment of the hernias of or abdominal tumor, and carefully use of the medication like opioids that reduce the bowel motility. Then after that we provide the management. In first management we give the medical management. In medical management we check the first to check the nil for oral. Okay, and also provide the nasogastric tube feeding. Nasogastric tube is inserted to decompose the stomach, which helps to relieve the abdominal distension like nausea and vomiting. And provide fluid electrolyte balance, also maintain. Then provide the pain management like provide the analgesic and also opioids to cause the avoid the reduce the bile motility. Then monitoring the vital sign to check properly and also detect the dehydration or shock is present. Then provide the antibiotic due to infection is present, to provide the antibiotic. And also lastly we provide the prokinetic. In prokinetic medication such as methoclopramide that may cause the improve the bowel motility. Then after that we provide the surgical management. In surgical management, firstly we provide the exploratory laparotomy. What is exploratory laparotomy? Exploratory laparotomy is performing as an open surgical procedure that identify and treat the exact cause of the obstruction and resection of the necrotic bowel movement. In resection of the necrotic bowel, it is the carried out the remove the dead or severe damage of the segment. Then adhesive lysis. Adhesive lysis is involved or cutting the removing the fibrous adhesion that cause the obstruction. And hernial repair. In hernial repair, to perform the restore the bowel continuity to prevent the recurrence. Then resection of the tumor. In resection of tumor, where or benign or malignant tumor is present or not, that we check. Then resection the tumor is done to relieve the obstruction and also to prevent the further complication. After that we provide the medical management, already we give, and surgical management we check, and also we give the nursing management. In nursing management, firstly to monitor, number one is firstly we monitor the vital sign. Okay, in vital sign to check the fever, hypertension or tachycardia and sign of the shock due to obstruction occurs. Then assess the bowel condition and maintain the NPO, okay, nil for oral, and also to check the intake output chart and provide the nasogastric tube feeding. In nasogastric tube care, we provide the maintain patency and correct placement and monitor the drainage, okay, and provide the IV fluid and electrolyte management, administer according to doctor's adscribe doctors prescribe. We provide the fluid and monitor the electrolyte balance. Then provide the pain management to reduce the pain. Then provide the skin care. In skin care, we provide the excessive vomiting occurs, then to provide the skin care. Then patient education to teach about the NPO and purpose of the nasogastric tube feeding. Then monitor the output chart. Then provide the lastly we provide the psychological support. After that we discuss about the nursing diagnosis. In nursing diagnosis, what we discuss, acute pain related to the intestinal distension and spasm. Then deficient fluid volume related to the vomiting, decreased intake or third spacing. Then risk of electrolyte balance related to the fluid loss and impair the obstruction. Then risk of infection related to the bowel ischemia, perforation or surgical intervention. Then anxiety related to the illness condition and hospitalization. Then in key point, first we summarize the topic. Firstly we discuss about the GI obstruction. In GI obstruction, what we discuss, introduction, definition, causes and risk factor of GI obstruction. Then pathophysiology, clinical manifestation like sign and symptom of GI obstruction. Then we discuss about the diagnostic evaluation of GI obstruction, and lastly we discuss about the management of GI obstruction. In management, to know about the medical management, nursing management, and surgical management of GI obstruction. Lastly we discuss about the prevention of the GI obstruction and nursing diagnosis of the GI obstruction. Already this all are we discussed. Then to conclusion is, GI obstruction is a serious condition that blocks the normal passage of the intestinal content. It may be mechanical or functional, that affecting the either the small or large intestine. Then early recognition and treatment that is essential to prevent the complications such as ischemia, perforation, infection and shock. Then prompt diagnosis, fluid and electrolyte correction and surgical and medical management can greatly improve the patient outcome. After that you can refer this book. I refer these books, okay, and also you also refer this book. And lastly I say